In this PowerPoint, we're going to take a look at sleep architecture and histograms. We will define those words for you as we go along. So let's go to our next slide. Sleep architecture refers to your typical pattern of sleep. Each night when you sleep, most people will start the night awake, then go into stage N1 for a few minutes, then go into stage N2 and spend several minutes in this stage of sleep, then progress on to N3 and finally into stage R or REM. This process then repeats 3 to 4 times in one night. During the process, N3 sleep progressively declines throughout the night. The majority of N3 sleep is recorded in the first half of the night. The amount of N3 changes as we age. For example, children will have the most amounts of N3 sleep across all ages, and then as we get older, the amount of N3 sleep will decrease. However, for one given night of a person, the majority of N3 sleep will be in the first half of the night. This is an important fact you want to remember. Now, in contrast to that, REM progressively increases throughout the night. What that means is that the majority of REM occurs in the second half of the night. Sometimes the first appearance of REM only lasts a few minutes, but then as the night goes on, you spend more and more time in REM sleep for that given night. Just like N3 sleep, though, as we get older, we get less REM, just like we get less N3 sleep. So again, another important fact to know is that the majority of REM sleep occurs in the second half of the night. Our first period of REM sleep usually occurs about 90 to 120 minutes after sleep onset. If REM occurs sooner than this, let's say at 20 minutes after sleep onset, this would be considered an abnormality. We'd want to do some further investigating. This would make us suspect that this patient either has deprivation of REM sleep, or they may have something called narcolepsy, which is a sleep disorder, and we'll cover that more as we go along in this course. So continuing on, although the amount of time we spend in each stage of sleep changes as we age, generally speaking, we spend about 5% or less of our total sleep time in stage N1, 50% or less of our total sleep time in N2, 20% or less of our sleep time in stage N3, and about 25% of our sleep time in stage REM. Sleep efficiency is another term you're going to want to know, and this term describes how much of the time spent in bed for a given night is actually spent asleep. Normal sleep efficiency is usually between 85 to 90%. So looking at the slide in front of you, just to review a couple of things. We start the night in stage wake or W. We then go into stage N1. Only a few minutes are spent here. Then we go into stage N2. We could spend a considerable amount of time in N2 at this point. Then we'd go into N3, again a fair amount of time asleep in N3, and then we go on to stage REM and spend just a few minutes in REM. Then the pattern would repeat, so we might go back to stage N1 and then go into N2 and then N3 and then REM, and this time in REM we'd spend more time, and this would repeat 4 to 6 times in one night. As I mentioned earlier, stage R or REM appears at about 90 to 120 minutes after sleep onset. REM usually occurs every 90 minutes after that, so your sleep cycle repeats about every 90 minutes. Stage N3 again is predominant in the first half of the night and then declines as the night proceeds. Stage R is predominant in the last half of the night, so it increases as the night proceeds. Stage N2 sleep, again we spend the most amount of sleep time in stage N2 for any given night. The breakdown for normal adult sleep according to percent of time of total sleep time. Stage N1 is only about 5%, N2 is about 50%, N3 is about 20%, and REM is about 25%. And then again, our sleep efficiency is about 85 to 90%. Let's go on to our next slide. Okay, let's talk about our sleep architecture versus our EEG waveforms. Sleep architecture refers to the pattern of sleep stages and wakefulness as a person transitions throughout their sleep process in one night. This is typically displayed on a histogram or hypnogram, or also a histograph. EEG waves are used to determine the different sleep stages and wakefulness. There are unique EEG waveforms which can occur with specific medical conditions. The two pictures in front of you are both of EEG waveforms. The one on the left is just showing the brain activity and eye activity. The one on the right is showing you the brain activity, the eye activity, as well as your EKG, your leg movements, your airflow channel, your thoracic respiratory effort channel, your abdominal respiratory effort channel, your SpO2, your EKG, and I believe your body position as well. That's pretty small type, so it's kind of hard to tell for me. The picture on the left, let's talk about that, because as you can see, that's showing you the brain and eye activity. The channel on top is actually your occipital lobe. The channel below that is your central lobe. And then the channel below that, which is a brighter blue, is your left eye. And then the channel below that is your right eye. And comparing that to the picture on your right of those same channels, notice they're more jagged, would be my description of it. And what you're actually seeing in the figure B below, this is an example of what's called alpha delta sleep. And we see this commonly in patients who have been diagnosed with fibromyalgia and chronic fatigue syndrome. And what it is alpha waves are the type of EEG activity that we see in our brain waves when we're awake. Delta waves are very big and slow waves. So when you see the alpha waves on top of the delta waves, this is abnormal. It shouldn't look like that. And again, like I said, it's common in fibromyalgia and chronic fatigue syndrome. There's some concern or some suggestions that maybe the reason we see this is because the patient's mind is waking up briefly, causing the alpha waves, and maybe that's why they're so sensitive to pain, is because they don't get their nice deep N3 sleep because of those alpha waves, but they're not for sure on that. In contrast, the picture on the right, outlined in red, those are the brain activity EEG waves, and you can see that they are nice and big, and they don't have those really tiny, fine, jaggedy lines on them. So those do not have the alpha delta sleep in that picture. Let's go on to our next slide. Okay, this is a picture of a sleep histogram. This is a graphical representation of a person's sleep architecture for an entire night. So when we talk about sleep architecture, it's the stages of sleep they go through and the process in which they go through it for a night. And this is a picture of sleep architecture. So you can get a lot of information just by looking at this picture. It's a very quick and easy way to assess sleep efficiency and the amount of time the patient is spending in each stage of sleep and wakefulness. The first thing I want to point out is you can see on the vertical line on your graph, it starts off at the very top with awake. So any line that is parallel to that, that is when the patient was awake for this night. Right below that is REM. Any line parallel to that, the patient is in REM, and they have nicely kind of shaded it gray for us too to help us out. And then below that you have stage N1, then stage N2, and then stage N3. Now this picture is a little outdated because it also has a stage N4. We no longer use stage N4. They actually combined stages 3 and 4, and we just refer to it now as stage N3. So anytime you see 3 or 4 on this histogram, assume they're all stage N3. So I'm going to walk you through this picture. We're going to start from the left where it has 0, and we're going to move to the right, okay? So find your 0 hours in the study. This is when the sleep study was started, and notice the patient is awake. As we move towards the first hour of the night, or number 1, the very first stage of sleep we see the patient go into is stage 1. After that, they go into stage 2, and then they go into stage 3. And remember, I said we're going to ignore the stage 4, so just assume they stay into stage N3 just beyond the first hour of the night. Shortly past the number 1 mark, then, as you follow your graph, they go back into stage 2, then they go into stage 1, and then they go into REM. Just before the 2-hour mark, they have achieved REM. Now remember, we said before, normal REM latency, or how long it takes to go into REM from sleep onset, is about 90 to 120 minutes. So this is pretty close to the 90-minute mark. Progressing on from here, after REM, the patient goes back into stage 2 sleep. Then they go into stage 3 sleep. We're now past the 2-hour mark. Then shortly before the 3-hour mark, they go back into stage 2, and then they go back into REM. And notice they've spent a little bit more time in REM now as compared to the first time they achieved REM on this night. Remember, REM's going to get progressively longer. After this, the patient wakes up briefly, and then they fall right back asleep and go straight into stage 1. From there, they go into stage 2, then they go back into stage 1, and then back into REM. Notice this patient doesn't go back into stage N3 sleep after this point. So just like we had talked about before, the last half of the night, they're going to have less stage N3 and more REM, and you can see that's what's happened here. After the first 4 hours of the night, they don't go back into stage N3 sleep. So after the 4-hour mark, let's see, they go back into stage 1, then they hit REM again, and it's even a little bit longer now. Then they go back to stage 1, then into stage 2, then they have a brief awakening, a very brief awakening, and then go straight back into stage 1, followed by stage 2, followed by REM again, and notice this is the longest REM period of the night. And then right at about the 7-hour mark, they go back into stage 2, and they remain there until just before the 8-hour mark. By counting the REM periods on this histogram, we see that the patient entered REM at about the following times. At about 1.5 hours into the night, or 90 minutes, then again at about 3.25 hours, which would be 120 minutes after the first REM period, again at 4.25 hours, which is about 60 minutes after the second REM period, and then at about the 6-hour mark, which was about 90 minutes after the third REM period. So again, normal sleep architecture, a person should go into REM about every 90 minutes, and this person does. So we are seeing someone with some fairly normal sleep here. Also, we pointed out that each REM period was slightly longer than the previous one, which is normal. We can count a total of 4 sleep cycles for this patient, and we count this by how many times they went into REM. So they went into REM 4 different times. Notice that stage N3 only occurred twice, and both of it was before the first half of the night. Some people might have N3 in the second half of the night, but the majority will be in the first half. So this is, again, a very normal sleep histogram or sleep architecture. So let's go on to our next slide. On this slide, we can compare 2 histograms and try to figure out which one is normal and which one is abnormal. I want you to just take a look at this for a few minutes and see if you can come up to your own conclusion. You'll notice the histogram is arranged a little bit different than the one we just looked at because it has wake at the top, followed by N1, N2, N3, and then REM at the very bottom. Okay, so let's compare the two. Starting at the picture at the left, notice how much time this person spent in stage N1 sleep and awake. They did get some REM sleep, but I don't see any time spent in stage N3. Now looking at the one next to it on the right, we notice how much time is spent in all stages of sleep. And by the red markings that identify REM, we can see this person had 4 different cycles of REM sleep. This person did get N3, and it looks like the N3 did decrease throughout the night. The only weird thing is that they had a lot of REM at the beginning of the night. So I would say the one on the right is a little bit more normal than the one on the left. But this person was probably sleep deprived or had some REM sleep deprivation, and that's probably why they had so much REM at the beginning of the night. So that's just an example of how you can take a look at a person's sleep architecture and gather a lot of information very quickly from it and kind of make an assessment through that. Let's go on to our next slide. Okay, this is a picture of our histogram and how it changes with age. And you can see on this diagram that we have sleep from ages 5 all the way to age 85. And really what it's done is it's combined several histograms for individual age groups, combined the information and created a graph to show us how sleep changes as we age. Let's take a look at the far left of the graph and see that it starts with age 5. Notice a 5-year-old is going to spend the majority of their night in stage N3. In our picture, they label N3 as SWS. That stands for slow wave sleep. That is how we describe stage N3. That's what the brain activity looks like, slow wave sleep. And that should be in purple on your graph. So there's a large amount of purple or slow wave sleep for the 5-year-old. Then if you look at stage N2, which is kind of the tan color, notice they have a lot of N2. And then they have stage N1 is green. And then blue, they have REM. And then you can also see their wake after sleep onset. They have very little wake after sleep onset. So once they go to sleep, they spend the majority of their time asleep. And then they have their sleep latency there as well in pink. Now let's take a look at a middle-aged person. Let's take a look at age 45 and let's compare it to that 5-year-old. So find age 45 on your graph. It's kind of in the middle. And let's start by looking at the stage N1 sleep and compare it to that of the 5-year-old. Notice our 45-year-old actually has a little bit less of that. Now let's look at our N3 sleep, or the purple part, the slow wave sleep on your graph. Notice our 45-year-old has significantly less slow wave sleep than our 5-year-old. So that tells us right there that as we get older, we get less of our deep sleep, of our slow wave sleep. Next, let's take a look at our REM, which is in blue. This one is a little harder to tell, but we do get less REM as a 45-year-old as compared to a 5-year-old. Next, let's look at our WASO, or our wake after sleep onset. Notice how much more a 45-year-old has compared to the 5-year-old. So as we get older, we actually spend more time awake after we've fallen asleep than a 5-year-old, or we spend more wake time in bed. And then lastly, I don't remember if we looked at N2, but a 45-year-old does have a little bit more of stage N2 as compared to that 5-year-old. Okay, let's take it a step further, and now let's compare the 75-year-old to the 45-year-old. So if you look on your graph there, find your 75. Here now, let's compare it to our 45 and our 5-year-old. Starting with stage N1, or the green. That of a 75-year-old is more than that of a 45-year-old, but less than a 5-year-old, so it's kind of comparable. For N2, a 75-year-old gets less N2 sleep than a 45-year-old or a 5-year-old. Looking at the purple, the slow wave sleep, now we see a huge decline as compared to our 5-year-old, and it is less than our 45-year-old. REM, there's also another decrease, although it's not near as significant. But then when we look at our wake after sleep onset, or our WASO, we see another significant change. There's much more wake after sleep onset time in the 75-year-old as compared to the 45-year-old. Another change we can see from this picture is the sleep latency, and that's how long it takes for a person to fall asleep. And that is actually a little bit longer for that 75-year-old as compared to both the 45 and the 5-year-old. So just to summarize, as we age, our histogram's going to change. We should still have a normal sleep efficiency, being about 85 to 95%. So when we're in bed, we should spend about 85 to 90% of our time in bed asleep. But the breakdown of how much time is spent in each stage of sleep, or the sleep architecture, will change as we get older. We get less of our deeper stages of sleep, and we get more of our lighter stages of sleep as we get older. Let's go on to our next slide. On this slide, I'd like to talk about thermoregulation in regards to when we're awake, when we're in non-REM sleep, and when we're in REM sleep. And yes, I have a typo there. It should say when awake, right under thermoregulation. Sorry about that. While we are awake, all of our autonomic and fight or flight functions are working. Autonomic refers to our automatic system, the things we don't control with our mind, but that our body just naturally does. These are things such as the ability to cool down, and we do that when our blood vessels open up or widen, which is called vasodilation. This also includes our ability to shrink our blood vessels or have our blood vessels constrict. They do this when we're cold. They try to push all the blood to our vital organs, and so down at our fingers and our toes, the blood vessels will vasoconstrict to try and protect our vital organs. Another example of our autonomic function is called piloerection. These are when your hairs on your arms stand up and make goosebumps. That's autonomic function. Another one would be shivering to warm up, or panting to cool off, and sweating to cool off. Those are all examples, and those are all working and functioning when we're awake. Now, when we go to sleep and when we're in non-REM sleep, now non-REM sleep refers to stages N1, N2, and N3. So all of the sleep stages except for REM. In non-REM sleep, we have some thermoregulation present, and that comes from our hypothalamic region, but it is not as intense as when we are awake. So if we get hot in the middle of the night when we're in non-REM sleep, our body will sweat and attempt to try and cool itself off. On the other hand, if we're cold, our body will vasoconstrict and try to maybe get goosebumps and try to shiver to keep our body warm. Now, when we go into REM sleep, all of the autonomic functions are impaired. We can't sweat, we can't create goosebumps, we can't shiver, we can't do any of our autonomic functions when we're in REM sleep. When we're in REM, that part of our brain is actually turned off, and it cannot control or regulate our body temperature. So to protect ourselves from extreme temperatures during REM sleep, if we were to experience an extreme temperature, our body will actually wake up. That way our body can manage the temperatures through its autonomic system. So if you think of that on a hot summer night, if you don't have your AC running and you wake up and you're sweating, more chances are you were in REM sleep and your body woke yourself up, so you were able to cool your body off. I hope that makes sense. If you have any questions, please post in one of the discussions and I can explain further. Let's go on to our next slide. Okay, in this slide we're going to talk about some of the cardiorespiratory changes which occur during sleep. As we fall asleep, we lose the stimuli of wakefulness. What this means is that we lose part of our central nervous system's control over the cardiopulmonary system. Our body then relies on metabolic control for respirations. So that means our respirations are going to change in response to changes in the carbon dioxide level, or CO2, in our blood. Remember, our body becomes less sensitive to carbon dioxide changes, or CO2 changes, when we sleep. The result of this is that our respirations become very regular. As this occurs, our body's going to rely less on the sympathetic nervous system control and more on the parasympathetic nervous system control. The increase in the parasympathetic tone brings the heart rate down. There is a decrease in cardiac output and blood pressure. The overall effect of this is going to be a decrease in myocardial work. So as we go to sleep, we lose our wakefulness stimuli. So that means we lose some of the control over the way our body's going to work. I can't make myself breathe faster on purpose when I'm asleep because I don't have the wakefulness stimuli. So once we go to sleep, when we breathe, it's all based on the chemicals in our blood. And remember, we breathe in response to carbon dioxide levels. However, when we go to sleep, we become less sensitive to those CO2 changes. So the result of this is that our respirations become nice and regular. Along with that, our heart rate's going to slow down, it's not going to pump as hard, and our blood pressure is going to drop, and the overall work on our heart is going to drop. This is all with normal sleep. Although in non-REM sleep, the parasympathetic system is highly activated, the sympathetic system can still take over control if it needed to. Now, just to review, the sympathetic system is our fight or flight system. So if it's activated during sleep, the result is going to be a brief awakening in our brain or an arousal. This arousal is going to cause us to take a deeper breath in, or an increase in our respiratory depth, and possibly an increase in our respiratory rate briefly. It's going to make our heart rate go up. It will make our blood pressure go up. So the point here is that an arousal, or a brief awakening in our brain, will increase our sympathetic tone, our respiratory rate and depth, our heart rate, and our blood pressure. So it's going to put more work on our heart, or our myocardial workload is going to increase as we arouse each time. So the more arousals you have during the night, the more of an effect that would have on your blood pressure, because each time you have an arousal, you're disrupting your sleep and that normal, relaxed state, which resets your blood pressure to a lower level. Let's go on and talk about REM sleep. In REM sleep, the cardiopulmonary effects are more similar to wakefulness than to REM sleep. In REM, a person has what's called phasic REM and tonic REM. In phasic REM, we see rapid eye movements, which some of us believe to be us watching our dreams, and possibly some muscle twitching. During phasic REM, our sympathetic tone increases, and we see changes in our heart rate and respiratory rate similar to that of being awake. The respiratory rate and heart rate become very irregular, and they coincide with the rapid eye movements. In tonic REM, we do not see the rapid eye movements, and the muscles are essentially paralyzed. Here, the respirations and heart rate are more regular, as in non-REM sleep. This is a unique balance between the sympathetic and parasympathetic tone, and it's unique to REM sleep. So here are some questions you should be able to answer, or that you want to be able to answer, I should say. The cardiovascular system should rest in non-REM sleep, which makes up about 80% of our total sleep time. Why is this important? Answer to this question. If a person has excessive, repeated arousals during non-REM sleep, for example, more than 30 arousals per hour, then that means their sympathetic system is being activated that often during non-REM sleep. This increases myocardial workload during periods where the workload should be the lowest. This is putting an excessive stress on the heart. While asleep, our respiratory system function decreases as well. We see a decrease in mucociliary clearance, cough reflex, which increases the risk of aspiration during sleep, loss of muscle tone of the genioglossus and palatal muscles. This increases airway resistance, and in select individuals is the cause of their obstructive sleep apnea. Bronchial tone is at a greater likelihood to increase due to the increase in parasympathetic activity and decrease in sympathetic activity. So I hope that gets your brain thinking a little bit and helps you put some of this in perspective. Non-REM sleep should be very quiet, relaxed sleep, so your heart can take a break from its daily activities, and so your blood pressure can reset at a lower blood pressure. REM then is your dreaming sleep, and it's very good for mental function and cognition. Any disruption in either of those stages of sleep will make your heart work harder, cause your blood pressure to rise, and put more strain on your overall cardiovascular system. Let's go on to our next slide. Okay, lastly, let's just wrap this PowerPoint up. The cycle of wakefulness, non-REM, and REM. This is our circadian rhythm, and this lasts on a time frame of just over 24 hours. With our circadian rhythm, when we look at the temperature over about a 24-hour period, we see that your body temperature falls in the late afternoon. It should be lowest in the middle of your sleep phase, so about midnight-ish is when your body temperature should be its lowest. And then just before morning, your body temperature will start to begin to rise. The lowest point of your temperature should coincide with the longest period of REM sleep for a person. And they can actually use that to study people and their sleep architecture or their circadian rhythms. They can actually use their body temperature to do that. It's pretty cool. They are doing it in many research studies. Next, let's talk about light and dark with the circadian rhythm. This has a very strong effect on maintaining the circadian rhythm. We call it photic stimuli, which is any type of light stimuli, and that actually has the largest effect on your circadian rhythm. If light is removed from a person, then the general circadian rhythm is maintained. However, the timing is slightly affected, so we see people have slightly longer circadian rhythms when we take that light away. If a person is struggling to get up in the morning, one of the first things a sleep doctor would recommend is seek light first thing when you wake up. So in the middle of winter, when it's dark all the time, if you're struggling to wake up at 6 a.m., as soon as you wake up, turn on some bright lights, and that should help set your circadian rhythm and help make it a little bit easier to adjust. Well, this concludes the PowerPoint. Please don't hesitate to post questions if you have them. I hope this is all working very smoothly for you. Thank you. Bye-bye.